got something to do with our bones.
Yes, tell me more, Mr. Jones.
It's also got to do with, like, the cartilage, I believe, of
Yep.
joints.
And what
ligaments.
Thank you. Yeah. And associated joints, but I love that. Bones, cartilage, ligaments, associated joints. Beautiful. Thank you. Mr. Singletary, you raised your hand?
Sorry, just hit the button twice.
Oh, okay.
I was going to answer the same question. Sorry.
No, don't be sorry at all. Okay, so anyway, I thought we would discuss those systems and pathologies of those systems just as a reminder. What's even more important than those pathologies, because honestly, there's no way to memorize every pathology there is. There's just not. You've got to, and this is true with all sorts of stuff in massage, right? What's tricky about massage is people are always like, what's the rule here? And there isn't a rule. You know, it's very different if a healthy person comes in presenting a certain pathology than if a sick person comes in presenting a certain pathology, right? And you just can't say in all cases you should do the same thing. So, please, if you remember nothing else, remember kind of the walk around the block philosophy of Tapscott. Assuming the person is somebody who can walk. I understand some people are in a wheelchair, but if they're in a wheelchair, can they wheel comfortably around the block on their own power? But if a client comes into you and they can basically walk around the block, and I just mean thematically, they don't actually have to truly do it, they probably can receive a massage, right? There might be certain contraindications. Maybe they broke their arm and you shouldn't massage their arm, but their general system is good enough. Can you walk around the block when you have a cold? Yes, you can. Can you get a massage when you have a cold? Yes, you can. Does it start to get hard to walk around the block when you have 103 fever? Yes, it is. Should you get a massage when you have 103 fever? No, you shouldn't. So it's just a good question to ask yourself, and it's not even exactly walk around the block, right? But you're asking yourself, is this person healthy enough that I can squeeze on them and rub them and I'm not going to make what's ever going on with them worse? And that's really what you have to remember, right? And the other thing that I think is really important to remember is the difference between local contraindications, relative contraindications, and absolute contraindications. Who wants to tell me the difference between all three of those? Anybody? I'm sorry, Miss Hendrickson, I was just trying to call on somebody else, so I was waiting to see if I had another. Miss Rader. Tell us the difference between all three of those.
So a local contraindication is confined to a specific area. So like if they broke their arm or,
Yeah, I broke my wrist, don't rub it.
Mm-hmm.
Right.
And then absolute is they can't be massaged at all. For people with fevers or anything like that, you don't want to massage them. And then I think that relative is kind of just like depending on the situation.
Yeah.
I don't know how else to explain it, but
they translate it as proceed with caution.
Proceed with caution.
I think everybody has a relative contraindication, right? Like I've got an ingrown toenail right now. That's a local contraindication. I'm trying to think. I am 52 years old, which is about 50 years older than Miss Savarino, who I'm looking at right now, and I mean that kindly. But my point is, she's in much better health than I am. I mean, just look at her. She's more vibrant. She's more elastic. All those stuff. So if you're massaging her, massaging me, we both like deep pressure, but you should proceed with relative contraindication. She's going to bounce back from your mistakes quicker than I am, right? That's a relative contraindication to take into consideration the person's relative health. We would say pregnancy is a relative contraindication, right? You can definitely massage a pregnant person, but I might not do abdominal massage in them. I'm not going to have them lay on their stomach, right? There's all sorts of things like that. So yeah, well said. So local is localized. Just avoid that area. You guys are going to have local contraindications all the time with clients. Yeah, double jointed is something to consider too, because that can be a problem actually. Local contraindications, there's something to really kind of pay attention to, and clients tell you these things that you forget. At least I do. So a lot of times when somebody would tell me like, hey, whatever you do, avoid my ankle, I'll sometimes change my massage and start with that leg where that ankle is, so that I finish that leg while I remember they have a local contraindication. Because in a 2-hour massage, after an hour and a half has gone by and I'm rushing down to your feet and I grab your ankle, and they're like, whoa, I told you my ankle was hurt. And I'm like, oh, I forgot, man, I forgot. I thought I'd remember, but I had an hour and a half to think about what I was going to cook for dinner that night, and when the elliptical machine's showing up, and, you know, how I'm going to get that right, and what bills are due and all that kind of stuff, and then you forget. So I recommend you kind of start in those areas so you can avoid those areas. Then you're like, well, I'm done with the arm, so now that I've forgotten about their hurt wrist, it doesn't matter. That's a local contraindication. You'll have them all the time. Absolute, and they're sometimes called general, means absolutely don't massage, and there's usually something systematically wrong with the person. So they are running a fever. You don't run a fever in your hand. You run a fever throughout your whole body. They're undergoing chemo and they're really sick from it. That's a systematic thing. That's not just, they haven't just irradiated their little wrist. That would be a local contraindication. So anyway, consider those things. And kind of consider that everybody is a relative contraindication, that everybody should be proceeding with caution. And this is coming from the guy who's like, go deep, go deep, go deep. I still say that, but go deep relative to that person, relative to what they need, relative to what's going on with their body. Yeah? Relative to how many times you've worked on them, too. If you've never worked on them before, I'm always a little bit more cautious to see how they respond. So, they've got to walk around the block, right? Or be able to be kind of at that state where they could, or they're feeling pretty good. You know, those are your main concerns, and know the difference between a local contraindication and a relative contraindication. And last but not least, remember about testing the corner of the carpet. This is what I call it. But when you get clean, and I know I've said all this stuff before, but you guys are getting ready to graduate, so it's time to make sure you leave here and don't hurt anybody. Remember, like, if you get carpet cleaning product, they often say test this on in the corner of the carpet in your room, and that's because if it lifts the color, they don't want to pay for replacing your entire carpet. Well, the same thing is true with clients. I've had clients come to me where they're like, I've got this knee problem, but it seems to get better when you massage it, and I'm like, I don't know, you know. But I'll massage it lightly, and then we see how it goes next time. If it's the same or better, we can do it again. But I like to test stuff out. I don't do a 2-hour massage on their knee when I'm not sure about what's going on. So less is more until you decide they're solid, and then go for it. Go for it, go for it, go for it. People like pressure. Even people that like light massage like pressure. It's just to them they feel it more. Yeah? Okay. Let me share my screen. Yay. Do. Boom. Feel free to ask questions on the way. Waiting for this to share. Pathologies. Yeah. Okay. So let's talk about the skeletal system. Yeah. Let's talk about frozen shoulder. This is one that you will get as massage therapists. The technical name for frozen shoulder is adhesive capsulitis, which really kind of means a stuck shoulder joint. It doesn't mean a shoulder joint, but a stuck synovial joint, because synovial joints have a capsule around them. So adhesive capsulitis is a frozen and inflamed, right? Itis means inflamed. Capsule, and synovial joints, which is most of the joints in your body, are synovial joints. They have a capsule around them, and that capsule gets irritated. It's itis, capsulitis, and adhesive means stuck. And frozen shoulder is a fairly common syndrome that people have. And people will come to you and say, I'm having a hard time lifting my arm up. And you'll notice that they compensate with their scapulothoracic joint. This is me lifting my arm with my torso and my scapulothoracic joint. I'm obviously not using my glenohumeral joint, which can go up to here. Now I can use my scapulothoracic to get up further. But they have a hard time actually doing this. If you hold down their acromion process, they can't get their arm out. That's the test for it. If you hold down their acromion process, they can't get their arm up to roughly horizontal. what they will do to try to get their arm up is they will lift it up a little bit and they'll start pulling up their acromion process. They're rotating their scapula, which lets you know there's a problem with the glenohumeral joint because they're not using it. And what often happens in here is there are tears in the labia, which is around the joint capsule. That's very common. But also what happens is they often get inflammation of the supraspinatus muscle. Supraspinatus muscle is part of what muscle group? Ms. Carrillo?
Rotator cuff muscles.
Thank you. Ms. Abelos, what are the 4 rotator cuff muscles?
Supraspinatus, infraspinatus, teres minor, and subscapularis.
Beautiful. Ms. Abelos, by the way, which 2 of
Here,
those?
a quick question
Yeah.
though. Is that where most of the tears and tendinitis occur too, through that fossa?
Yeah, do you mean,
Or not fossa?
no, it's okay. But do you mean in that joint or with those muscles?
Yeah, in that joint, right there inside of that.
Yes. So, shoulder joints are extremely prevalent. And why do you think that's true?
Come again?
Shoulder joint problems are one of the most common joint problems in the human body, and yet the shoulder is not carrying around your body weight. It's not like a knee or whatever. So why do you suppose there's so many shoulder joint problems?
Well, there's so many different movements that are affiliated with the glenohumeral joint. I mean, I think it's almost all of them.
Yeah,
You have
it is all of
extension, flexion, adduction, abduction, medial, internal, lateral.
Externally.
You have horizontal adduction, horizontal abduction. I mean, you have every movement possible
Yeah.
that goes through that joint, so it's bound to get inflamed and overused.
Yeah, that's one reason. You're absolutely right. Because of its wide range of motion, it's not as strong, too. You're absolutely right. Yeah, Ms. Carrillo, do you have more to add to that?
Yeah, it can do all those motions, but the ball and socket it has, it's the glenoid fossa is not, it's not big. Like with the acetabular, it's bigger and it encompasses here, but with the glenoid fossa, it's more like in here. So it's bound to how you pop your shoulder out of place and everything.
Excellent addition. So Ms. Abloh said that you can move your shoulder in all sorts of wide ranges of motion, things like that, and she's right about that. And then Ms. Carrillo added, which she's right about too, that the glenoid fossa, they call it a socket. There's no socket there. It's a teaspoon. It's literally a teaspoon like you eat your cereal with. And I don't mean the big spoon that some of you use because I watch you on this camera. Some of you are like using not even a soup spoon. It's like a ladle. You know who I'm talking about. Anyway, it's a teaspoon, and it's so easy for the humerus to pop out of that teaspoon, which is why you need strong shoulder cuff muscles. Whereas the hip actually gives you a true socket to hold that in there. Yeah, awesome. Okay, so Mrs. Hendrickson, please.
I would just add that, like, no matter what job you have, if you're doing, like, the same job all the time, you're probably going to be using repetitive motions. So, you know, either holding your arm up, like a hairstylist, or what we do, like, no matter what your job is, if you're doing the same thing all the time, you're going to have an overuse injury if you don't correct your posture.
Yeah, very true. The other thing, Mr. Jones will attest to this. I don't mean that he does this, but he'll attest to this. He'll see it in the gym, too. A lot of people overuse their shoulders. Your pectoralis major is a massively powerful muscle. When you do bench press, you're actually putting a tremendous amount of pressure on this shoulder joint, and in a way, the pec can handle more than the shoulder joint can. And so people do way too much bench press and things like that, too, and that puts a lot of force on there, too, and kind of starts to, once those muscles tire, once the rotator cuff muscles tire, that shoulder joint doesn't have as much support, and then ligaments start to take over, and once those start to stretch, you get inflammation in here. And if you get inflammation, especially in the supraspinatus tendon, because it goes under the acromion process and hooks in here, when it swells, I don't have room to lift my shoulder up anymore. And then what happens with a lot of people is they hold their shoulders still to let it heal, and it starts to get frozen shoulder in there. And they actually can benefit from massage, where you start to increase range of motion with their shoulder. And the way you do this is to control their acromion process. Because I don't want to lift your shoulder and just have your scapulothoracic go up. That's not working. What I want to do is gently stretch your shoulder out while holding your acromion process in place. So I'm actually starting to open back up the joint capsule very slowly on my power, not yours. Miss Rader, please.
So I'm just curious. I'm sure it's probably all of the rotator cuff muscles that could cause that, but the book in chapter 21 says that the subscapularis is called the frozen shoulder muscle. It says because myofascial trigger points may lead to shoulder immobility. So is there a way to work on that? I mean, what would you do if that was the case?
Yeah, so two things. One is I would have said the supraspinatus. I mean, I just did. And I'm not always right, but my experience has been the supraspinatus is a bigger issue because it goes through this small little underneath the acromion process and it pinches itself. But how to get to the subscapularis? Yes. So the subscapularis, I think the best way to get to it is when somebody is supine on their spine, on their back. You open their arm up like this, and believe it or not, right now my shoulder blade is out here, and I put a sheet over my hand and then press into the anterior surface of the scapula, and you can from there. The reason I put a sheet over my hand is not because the axillary region is gross. I do it because it's a really sensitive area, and there's something about having a sheet over my hand that keeps the person from feeling extra ticklish and extra pokey. It's just very effective. I was shocked. Another massage therapist showed me this. And she's like, I got this really great trick for working the subscapularis, and I thought it was going to be something amazing, like you put them upside down and put their hand over here. And she's like, no, I put a sheet over my hand, and literally inside my head, because I'm a jerk, I was like, that's the stupidest thing I've ever heard of. That's what you're telling me? You put a sheet over your hand. Anyway, I tried it. She's brilliant. I'm an idiot. It works really well. So I put a sheet over my hand every time, and you can rub right in there and get into the anterior surface. Remember, the subscapularis is actually on the front of the scapula. It's not the front to us because we're always working on the back of it, but it's right in here. And you're not going into the axillary region like I'm doing right now. You're going back. That's the subscapularis there. That's into the armpit. Don't do that. That's a no-go zone, right? But you can go back into the anterior surface of the scapula. Yes, you can. Miss Carrillo.
So you kind of like slide off laterally until you hit it, basically?
Yes. Yes. Well said. You slide off laterally and move posteriorly.
Okay.
Does that make sense? And you should rest on the shelf of the scapula. And you can push as hard as you want on the that's kind of what makes up your posterior border of your axillary region. So what makes your armpit is that you have two borders. I've got a big pec coming down here, and I've got a latissimus dorsi and a scapula coming down here. And so yeah, you go in until you hit the scapula. So I'd say move laterally and posteriorly. Don't move medially, because that's when you're going into the axillary region, right? I'm going in towards the ribs. Don't move towards the ribs. Move towards the back. Mr. Singletary.
Okay, so just make sure I got it. So I just thought that the supraspinatus, you can only get it from the posterior side, but if you're saying if you raise your arm, you can get, if the person is lying on their spine,
Well, wait.
you can reach it.
Just be very careful, because there's two different muscles. I was talking about the supraspinatus originally. Which you can, I mean, I guess you kind of get it from the back, right? It's back here, but it's really on top. Anyway, you can get it from the top here. And it goes underneath the acromion process, and so it can get pinched very easy. I think it's a major culprit of most frozen shoulder. Miss Rader was bringing up that the book says subscapularis is a major culprit. And then I was talking about subscapularis. So very different muscles in very different places. One's on top, one's in front. Yeah.
Yeah, I got it now. I was confusing the two muscles.
It's easy to do. We have so many muscles in our head now that somebody was just talking about their rhomboids in gratitude, and I had to stop. I had to stop and think for a second, like, rhomboids? Rhomboids. Wrong. I was like, oh, the most common muscle in the body. Wrong way. Yeah.
Okay.
Mr. Richards.
Do you know how we was taught to loosen all the muscle around the scapula, then you can lift the scapula? Could you reach the sub that way as well?
Yes, you could.
So if you
I
lift the scapula on that side, then rub on.
It's one of the
you could do
reasons.
same, right?
Yeah, I don't know. It's not going to be as direct, right? You're going through more muscles. But if you really think it's the subscapularis, I would do both, because then you're over here. I'm kind of hitting the anterior lateral part of the subscapularis. By lifting up and back, I'm hitting the anterior medial part of the subscapularis, and you're hitting both. But you're absolutely right. That's why I love lifting scapulas, because when I lift them, I'm stretching rhomboids major and minor, right? I'm lifting the levator scapula as well. I'm reaching under and touching the subscapularis and kind of loosening it up. And I'm going through at least at the middle, if not upper fibers of the trapezius. So I've now hit 5 muscles with one move. And I'm always looking for, like, areas where there's lots going on. So yes, I love that thinking, sir. You're absolutely right. Okay. So anyway, the idea with this, too, with this frozen shoulders, you're trying to just increase range of motion. And so you hold the acromion process in place and slowly stretch. And you check in with the client. But you can stretch these areas out. And then you see how they feel next time. If they're like, oh, my shoulder started swelling up and I lost movement, it's like, oh, well, we went too far, did too much. Usually it's quite effective. And you start increasing range of motion and getting back to normal range of motion. It's actually, massage is very effective for frozen shoulder, unless it's gone really, really, really far. And then sometimes they take them into surgery and actually break the shoulder free, which I don't like that method, but they do. Miss Hendrickson.
On Thursday, Miss Bauer showed Mr. Upperman a move on me. It was pretty amazing. I was like face down, and then she put my arm like up above my head, and then went like all along the side, like just like with both hands. And I don't know, like it was just touching like all these different areas, and it was amazing. I don't think I have like frozen shoulder down like that, but I do have some like mobility issues in my shoulder. It helped a lot. It was a really good move.
Yeah. So when there are shoulder problems, everybody, first you want to identify, and it could be both, but is it a scapulothoracic problem or a glenohumeral problem, right? If it's not a scapulothoracic, they can move their scapulothoracic all around, then it's a glenohumeral problem. Sometimes it's both, but that lets you know what to work on. You're absolutely right. Yeah.
Gotcha.
So, and it could be both, by the way. And if it's both, you've got like 75 muscles to work on. Not really 75, but it's a lot, right? There's a lot of muscles that move those joints around. Yeah. It's not 75, it's like 12 or 13 or something. Okay. So that's frozen shoulder. And the reason I made such a big deal out of it, we just spent so much time talking about it, is that you will get clients that come in with at least mild frozen shoulders all the time, and you can actually improve them with massage. Baker's cyst is not something that you really need to worry about. We usually ignore it completely, and lots of people have them. It forms behind the knee, and it feels like a fat nodule that's usually, I don't know, about the size of a nickel, sometimes a quarter. And there's nothing to worry about, but we don't rub it. It usually starts from an injury, and it's just kind of left over, and they're super common. The real reason that common injury. The real reason we bring it up is because you're going to find it on people a lot. You're going to be like, there's this weird bump behind their knee. That's a Baker's cyst, and it's just super common and nothing to worry about. Mr. Singletary, yes, sir.
Are we able to massage around that? Because I had one of the clients in clinic. She clearly had a Baker's cyst on her knee. And I thought, okay, local contraindication.
Yeah.
I better steer around this.
Yeah.
She said it was okay. I was scared to touch it.
It is okay. The reason they say it's a local contraindication, like it's one you can work very closely to it. What they don't want you to do is to think it's a knot and start digging away at it, right? And so as long as you are not going over the bump itself, you're fine. And by the way, if you accidentally run over it, you're still fine. Just don't start working on it.
Okay, so no deep tissue there.
No, just don't try to not rub the thing at all, but don't freak out. It's just not a big deal. But definitely no deep tissue on it. Yes, you're right.
Gotcha.
Yeah, some people it's very sensitive to touch too. Some people it's not even sensitive to touch. It's been there so long it's kind of scar tissue over and it's just there. Who can tell me what a Bursay sac is? A Bursay sac. Miss Carrillo.
If I'm remembering correctly, it's that sac that helps glide between the, what is it, the tendons? The tendons
Usually.
or muscles to glide between each other?
Yeah, both actually, but yeah.
It's like big.
Yeah. Well, the sac is small. It's usually tiny. And it is like a synovial joint sac without a joint involved. So it's got synovial membrane around it, and it's got lubrication in it, and it helps tendons and ligament, usually tendons, but ligaments and stuff slide over this sac. And you'll find it in people's elbows, their shoulders, and it can get inflamed. And when anything gets inflamed in the body, it's called itis. So that's bursitis. So you will get, by the way, you'll get people come in and they'll say, I've got ligamentitis, I've got tendinitis, I've got bursitis. In my mind, those are all the same. Now, they're not really the same. Ligamentitis really is inflammation of ligament. Tendinitis is really inflammation of the tendon, which attaches to muscle, right? And bursitis really is inflammation of the bursae sac. The reason to me they're all the same is they all occur around a joint, and quite often a doctor has quickly diagnosed it. So it's not that they can't better diagnose it, but a lot of times if you go to a doctor and you say, oh, my elbow's kind of acting up, they go, oh, you got some bursitis there, you got ligamentitis, you got tendinitis there. They're not actually stopping to figure out which one it is. They're like, take some anti-inflammatories and come back in a month if it still bothers you. Because it's so common that usually the anti-inflammatories kind of knock it out and they're done. So clients come to me and say, yeah, my doctor told me I've got this thing. And I'm like, okay, so you've got some type of inflammation around your elbow. I am not 100% sure it's truly ligamentitis, tendinitis, or bursitis. And if the swelling's not bad there, you can actually massage it, but you don't dig into it. You're just careful about it. And if there is swelling there, you leave it alone, right? But if they're like, I've got a little bit in there, but it seems like it's getting better, you can actually work on it and stuff. Yeah. Cool. Bursitis. You're going to hear itis all the time. Just remember, the person's just telling you they got inflammation somewhere. Dislocations and subluxations, yeah. We normally, if somebody has a dislocated shoulder or something like that, don't work their shoulder. I doubt they would come into you with a dislocated shoulder. It would have been put back in by then. Subluxations, though, is a term that a lot of chiropractors use for when your back is out of alignment, when the vertebrae are slightly off. Remember, they're not truly out. If they were truly out, you would be dead, right? These are tiny little things, and they call them subluxations of your spine. And they'll be like, oh, you've got 10 subluxations. Everybody's got 10 subluxations for some reason. And they will adjust those. And that can be very helpful, by the way. But that's when it's commonly used. Fractures are just like what they sound. They are when there is a break in the bone of any kind. There is all sorts of types of fractures, whether they're compound. You won't see a compound fracture on the table because that's when the bone actually pokes through the skin. And obviously that person needs to go to an emergency room. So most people will come in and complain of hairline fractures. They'll be like, oh, avoid my shins. I've got hairline fractures there from all the running I've been doing. Okay, local contraindication. And by the way, not that dangerous to work on even. It's just that they'll yell at you because it's really painful. Stress fractures, exactly. Those of you that have been in the military know all about stress fractures because they run you until you get a stress fracture. Oh my gosh, yeah, all the time. Yeah. We will take a break here in just a second, by the way. A ganglion cyst. Yeah. You can actually work on these. It's a sac of synovial fluid, and you will sometimes see them kind of down in people's wrists and hands in here. They'll get like a little cyst in there, and you can actually work on them as long as the client's okay with them. And I've actually worked on people and had their ganglion cyst disappear. Yeah, almost overnight. Like, yeah. where they're like, nope, it's good. And what we did was we tested the carpet first, we massaged it, right? And they came back, they're like, definitely not any worse. And so I went to town on it, and it went away. I've had that happen before. Gout. Gout is a contraindication because it is an inflammation of the joints caused by uric acid building up in the joints. And it's an inflamed joint, so you'd leave it alone, right? And before break, and we'll take a break right after this, let's talk about kyphosis and lordosis. And I think this is I just don't know if I like your books. There's a mistake here. Okay, there is a mistake in this slide. Kyphosis is usually an exaggerated curve outward, and usually it's of the thoracic region. So when you see a person who's really hunched over, that big hump, that's kyphosis. Lordosis is usually exaggerated curve inward, and it's usually referring to the low back. So that's lordosis, right? And I always just kind of remember, because I remember my grandmother walking around being like, oh Lord, right? Lordosis, exaggerated curve of the lower back. Kyphosis is that kind of humpback. The terms actually really just mean exaggerated curve in or out, but almost always kyphosis is the upper back and lordosis is the lower back. And you can work on these individuals. It's absolutely fine. But remember, when your spine changes, it tends to change your hips. Or when your hips change, it tends to change your spine. So we always look at the hips when we see things like kyphosis and lordosis. The other problem with kyphosis is that they tend to get an exaggerated curve of the neck now. They get lordosis in their neck, believe it or not, because they got to get their head back up here. So you get this very crooked person. In general, when one curve increases on your back, the other curve increases too. And when curves go away, they both go away. And you want gentle curves in there. That's in general what you want. All right, this is a good place to take a break. It's 9:31. We can come back at 9:46. Thank you all so very, very much. Okay, everybody. It's 9:48, and we are back. When we last left our intrepid explorers, we were talking about lordosis and kyphosis. Personally, I could care less about those names. What I care about is that you remember what happens when pelvises tilt. So, when a pelvis tilts anteriorly, what happens to the curves of your spine? When a pelvis tilts anteriorly, what happens to the curves of your spine, Miss Carrillo?
The upper back starts. When the pelvis is tilted anteriorly, the upper back starts getting hunched, but then the neck starts pulling the head.
Yes. What we would say, by the way, you're 100% correct. We would say all the curves start to exaggerate. Right? So the low back curves more to try to get you back here. The upper back curves more, and the neck curves more. The curves exaggerate. You start to see somebody get very curvy. In general, by the way, there's always some exception to the rule. But yes, thank you, Miss Carrillo. The curves exaggerate when we have an anterior tilt. They get greater. So I'm now going to call on somebody at random and ask what happens when we tilt posteriorly. And just as a clue, those curves would do the opposite of this. When you go anteriorly, they exaggerate, they get greater or bigger. When you tilt posteriorly, when your hips do, the opposite happens. So, what happens when your pelvis tilts posteriorly, Miss Young?
You get like a hunchback where it exaggerates backwards.
No, your curves go away.
Well, that's what I meant.
You get like military back. You get kind of straight. Does that make sense?
Kinda. I don't know. My drawings are confusing.
So, can you see me in this?
Yes.
So when my hips tilt forward, what happens is I have to start curving my back to keep my head over here. It's hard for me to even do.
Mm-hmm.
When my hips tilt back, I start to get I lose curves, so I start to get this very military back. Does that make sense?
Yeah, but doesn't your head kind of have to go forward to like even everything out, and then you kind of get like a hunchback?
No, it's really good question. But if you think about it, I've got this curve in my lumbar, curve out my thoracic, curve in my neck, and that all keeps my head up here. If my hips here go forward, my head's got to get back here somehow. And it does that by curving the curves even more. If my hip goes back, these curves have to go away. That's the thing. So in general, a posterior tilt gives you no curves, and anterior tilt gives you exaggerated curves.
Okay.
Thank you, ma'am. Thank you.
Thank you.
So an anterior tilt, I'm just reviewing this again to make sure people are paying attention. An anterior tilt does what to the curves of my spine, Miss Stevens?
Sorry, my mouth's full.
That's
An
okay.
anterior tilt,
Yeah. Does
it exaggerates the curves.
Thank you, Miss Stevens. A posterior tilt does what to the curves of my spine, Mr. Singletary?
Sorry, it lessens it.
Yes! Gives you kind of a military back. Awesome. Thank you. An anterior tilt does what to the curves of my spine, Mr. Richards?
Repeat the question, please.
No, it's okay. An anterior tilt of my pelvis does what to the curves of my spine in general?
Exaggeration.
Exaggeration. Let me ask you one more question, Mr. Richards, just because you're on the line. I have not asked this. What does a lateral tilt or lateral elevation of my hips do to my spine? What do you suppose it might do? It creates a condition.
I can't think of the word. It's when the spine goes out.
Thank you.
Back.
Scoliosis.
That's scoliosis. That's it. Yes.
Yeah, good job. Excellent. Yes, it exaggerates curves where there should be no curves. Your spine is supposed to be straight from left to right, laterally, right? And then what happens is my shoulders have to go over if my hip comes up. Yes. So an elevation, a lateral tilt of the pelvis or a lateral elevation of the pelvis creates scoliosis. Thank you. Thank you. Thank you. Mr. Overman, what does a posterior tilt of the pelvis do?
A posterior tilt would lessen the curves of the spine.
Yes. What does an anterior tilt do?
It would exaggerate the curves of the spine.
Yes. And what does a lateral elevation do or a lateral tilt of the pelvis do?
Causes scoliosis.
Mr. Overman could not have said it better myself. Thank you, thank you, thank you.
Absolutely.
Miss Mares, what does an anterior tilt to the pelvis do, madam?
It creates a hunchback, which exaggerates the curves.
Beautifully said. Thank you, ma'am. Mr. Ma, what does a lateral tilt of the pelvis create? A lateral elevation where one side comes up.
Yes, sir. I'm listening to remember that pronunciation.
That's
But
okay. Do you want to say
I
it?
catch that. Yes.
But it sounds like you know it, though. So it's scoliosis.
Scoliosis.
Yes, and it's where my spine has curves where it shouldn't have any at all. My spine's curving to the left and right, laterally and medially. Scoliosis. Yep, good job. Thank you, sir.
Scoliosis. Thank
Yeah.
you, sir.
Miss Lee. What?
Hi.
Miss Lee, same question as Mr. Ma. What does a lateral tilt of the pelvis create? And
Scoliosis.
yeah! Bam! Thank you. Love it. Scoliosis. Miss Hendrickson. What does an anterior tilt to the pelvis create?
An anterior tilt creates an exaggeration in the curves of the spine.
Yes. And how do we measure an anterior tilt? I mean, how do I know? Because really, my hips are kind of round, so anytime a part goes forward, another part goes back. So, you know what I mean? Where are we talking about when the hips tilt forward?
at the cross section of the ilium or the
We would.
iliac crest.
Yeah, thank you.
Okay.
The top of the hips, the iliac crest. Because really, guys, remember when the top goes forward, the bottom goes back.
Right.
I'm
so it's
anteriorly
like
tilted right now, and my butt's sticking way out back. So we have to
Yeah.
measure it from some point, and Miss Hendrickson was exactly right. We measure it from the top. So when we talk about anterior tilt, we're saying the top goes forward. Posterior tilt, the top goes back. But believe it or not, when the top goes back, the front goes forward. So it's a steering wheel. Miss Osuna, please talk to me.
Yeah, I have a question. On the posterior tilt, does it permanently cause a slight bend in the knee?
I don't know about permanent anything, but I could definitely see why it would cause bends in the knee. Yes, because again, your body is trying to stabilize over that. You're kind of curved all the way up and down your body in a way. Have you guys ever thought about this? By the way, I curve. Think about this for a second. I literally curve out over the back of my head. The back of your skull goes out. Then I curve in at my neck. I curve out over my lumbar. I curve back in. Back over my thoracic region, in at my lumbar. We curve out over our bottoms, right? And then what does the femur do? It curves in from the back. It is a curved bone. And then you curve back out over your calves. You curve in at your ankle and back over your heel. You are S-curves all the way down. And so yes, Miss Osuna, I could see it creating curves and creating bend in your knee. Absolutely. It's a good question. Miss Mares, yes, ma'am.
Would that affect the psoas major and the iliacus
Yes,
for the anterior?
yes. In fact, that's brilliantly said, madam.
Well, I remember from last time.
Well, good. Well, brilliantly remembered. Very likely culprits, if you are anteriorly tilted, they probably, but not for sure, have a tight iliopsoas or a psoas major and iliacus. Those are the same thing. Yeah, thank you. Nice job. She's like a steel trap. She remembers everything. Finish up here really quick. Where was I? Mr. Godot, what does an anterior tilt of the pelvis create?
Hello?
Hello?
You said, yeah.
I said,
anterior.
yes, sir. Anterior tilt. What does it do to the curves of your spine, an anterior tilt?
Well, hold on. You're just explaining it. The anterior, posterior. I'm trying to do it in my head. So it creates what is the question? It's like,
what does an anterior tilt of your pelvis do to the curves of your back?
oh, it brings them out, exaggerates them.
Very well said. Thank you. Exaggerates them. So what does a posterior tilt of your pelvis do?
The opposite. Not exaggerate them as much.
That's true. It takes them away. It can actually remove them entirely, basically. And what does a lateral tilt or a lateral elevation of your pelvis do?
Does it just make it neutral?
Nope. If one side of my hip goes up, what does my spine have to do?
Curve?
It does have to curve. What do we call it when my spine curves laterally? Yes, say it.
Scoliosis.
Bam. Thank you, sir. Thank you. Mr. Bose? Mr. Bose, what is it? What does an anterior curve of the hips create?
An exaggeration of the curves of the spine.
Thank you, ma'am. What does a posterior tilt create?
It lessens the curves of the spine.
Yep. What does a lateral tilt or lateral elevation of the hips create?
Scoliosis.
Yes. Why am I running this idea into the ground so much? What's your guess?
I feel like it's a common thing. I feel like posterior and anterior tilt are probably very common.
It's super
For all
common.
the people that are going to come in, so
Super
we're going
common.
to need to figure out how to massage them and how to help them a little bit.
Well said. Thank you, Ms. DeBose. I'm running this. Ms. DeBose is right. I'm running this in the ground because it's a super common thing. But also, what we're trying to do now, you guys are seniors, is to stop thinking muscle sore, me rub here. Right? Hopefully, you were doing that when you were freshmen. Muscle sore, me rub here. What we want you to do is still be like muscle sore, me rub here, because client asked me to rub here, right? But we're going to move out of the cave, right? And we're also going to be thinking like, oh, this person's neck is really jacked up. Maybe there's a problem with their hips. Or maybe there's a problem with their feet. We want you to start thinking in chains. Or, oh gosh, the rhomboids are tight. I wonder if their serratus anterior and pectoralis minor are tight because they are fighting them. We want you to think more globally. So that's why I'm running this in the ground. Let's see. Miss Dang. Miss Dang?
Yes.
Miss Dang, if somebody has a lateral tilt to the pelvis, what do we call that? What does it do to their spine?
Scoliosis. Scoliosis.
Oh my gosh, I love you. Yes, scoliosis. Say it one more time.
Yes. Scoliosis.
That was beautiful. Scoliosis. Thank you, Miss Dang.
Thank you, sir.
Wonderful. Miss Clayton.
Yes.
Miss Clayton, if people have back problems, could they be coming from their hips?
Yes, they may have a posterior tilt, an anterior tilt, or a lateral tilt.
Thank you. They can also, by the way, everybody have what's called a torquing, which is where the front of their hip kind of tilts in and the back kind of tilts back and they're actually torqued. But that's a whole other thing. Thank you, Miss Clayton. Miss Abelos.
Yes, sir.
Can you summarize what I just said about hips in your own words?
Oh, God.
I'm
Okay.
sorry, you're last on the list. And I got to the top and I'm like, you're a good summarizer. You're a good summarizer. Go for it.
Okay. So there's an anterior tilt where your hips are rotated forward and it creates an exaggerated curvature of your spine. There's also posterior tilt, which is rotated backwards. It removes the curvature and creates like a military back. The lateral tilt is an elevation on one side. It causes unwanted curvature, and it's also known as scoliosis. In order to find which type of tilt you're dealing with, you have to look at the top of the hip, at the ilium. There's also a kind of tilting that occurs where one part of your hip is forward and one's rotated backwards.
Oh, Miss Abelos. The end. That was a big thing to throw at you, and you did great. Yeah, everybody, remember that. Thank you, Miss Abelos. Miss Young, you have your hand raised.
So I couldn't hear what you called it. I think you called it a torque.
Yeah.
Does that mean you like kind of walk like mainly with one foot? Because
yes,
it's like, would it affect the top half of you too, or just the bottom half of you?
It seems to affect everything, but it's literally like you are twisted. And torquing is really difficult to deal with in massage because what usually happens is I'm kind of tight on one side in front and tight on another side in back, and then I'm kind of walking forward in a weird manner. And yes, most massage therapists call it torquing, but it's an uneven rotation, right? Like my upper body's often going one way and my lower body's going another way because I got to walk forward still, and it creates all sorts of problems. But everything I've just discussed kind of holds true even with torquing. It just goes from back. It goes back and forth. Like if I'm torqued, usually then let's say if I'm torqued this way, probably my right side is tight in front, but my left side is tight in back. That kind of thing. You have this kind of uneven tension that creates a corkscrew effect in your body. And yes, it does all sorts of stuff. And it could be due to a foot problem. It could be due to hip problems, back problems. It could be it could be a birth defect, by the way, too. Some people their bones go that way, and that for them you're just alleviating their symptoms with the massage. You're not going to fix it. That answer your question? Thank you, man.
Yeah.
Cool. Awesome. I love it. Okay. We don't need to talk about Lyme disease. I mean, it can cause all sorts of problems, but osteoarthritis. What does osteo mean? Who can tell me what osteo means? Miss Savarino, I feel like you were leaping for the button.
It's bones, Mr. Tatchcott.
Bones, yeah. So osteoarthritis is inflammation around your joints. It's actually a breaking down of the cartilage and such. And believe it or not, if they are not swollen at the time and it feels good to them, you can gently rub those joints if they're not swollen at the time and it feels good to them. But really important, remember osteo, right? And this had arthritis at the end. Arthro is like how you articulate, and os means like your bone articulations are inflamed. Itis, right? Osteoarthritis. Cool, cool, cool. Love it. Osteoporosis, that is an actual weakening of the bone. And we do need to be careful about this. If you have, some of you like getting on top of massage tables. I commend you. I like getting on top of massage tables. Don't do it in an interview, by the way. But there's nothing illegal about it. It's okay, some of you like getting on top of massage tables, but I'm not going to get on top of a massage table and put my knees into the hips of somebody who has osteoporosis. Their body has brittle bones, and it doesn't need another 230 pounds of Tapscott coming down on top of them, right? Whereas I wouldn't think twice, sorry, just to use this example again, I wouldn't think twice about doing that to Miss Savarino. She doesn't have osteoarthritis, she likes really deep pressure, and she's smiling right now, and I'm looking at you, that's why I picked on you. But, and I would hop up there and pop those knees in there, and she'd be like, thank you. So if somebody tells you they have brittle bones, don't be afraid to massage them, by the way. They're not so brittle. If they walked in, you really can massage them. But that's not the time to be like, I'm going to use these moves where I crush their rib cage down, right? Or I crush their hips down. So do be careful about osteoporosis. Patellofemoral pain syndrome is really kind of an arthritic condition around the knees and such. Nothing to worry about. If it's not inflamed, you can massage it. Rheumatoid arthritis is arthritis again. This is where the body's actually attacking its own joints. Scoliosis. What type of hip condition can cause scoliosis, Mr. Snell? What type of hip condition, we just discussed this, by the way, I'm just asking the question a different way. Mr. Snell, Mr. Snell, what kind of hip condition, like what do my hips have to do to give me scoliosis?
It'd be like a lateral.
Thank you.
Under the hips.
That was beautiful. Lateral tilt to the hips. By the way, everybody, this does not mean everybody with scoliosis has lateral tilt to the hips, although they usually do because they're compensating for that. Scoliosis, it can be a birth defect and all sorts of stuff. I'm just saying that when people have these lateral problems, you will see them compensating in a scoliosis-like manner. Well said, sir. Thank you. Let's see. Spondylitis. You'll get a lot of clients have spondylitis. It's a degeneration in the spine. Should not prevent you from massaging them at all. Sprains, and I'd like to talk about strains. Sprains involve, in general, ligaments. What do ligaments do? They attach what to what? Ms. Hendrickson.
Bone to bone.
Bone to bone. And what do tendons do, Ms. Hendrickson?
They connect muscle to bone.
Thank you. Sprains are a ligament problem usually, a torn or pulled ligament. Strains are a tendon problem. And you can remember this because when you're lifting weights, you are straining to lift weights. You're not spraining to lift weights, you're straining. So muscle strains and ligament sprains. All this stuff, though, by the way, is actually fairly serious. You can massage it if it's not swollen. I don't mean that. But tendons and ligaments tend to repair slowly. Why do they repair slowly? Why do tendons and ligaments repair more slowly than muscle, Miss Rader?
Because they're mostly avascular.
Yes.
They don't have a lot of blood going to them.
Yes, tendons and ligaments do not have the blood flow going to them like muscles do. Now, muscles need that blood flow because they can't be contractile tissue if they don't keep getting new nutrients in to contract over and over again, right? But what's the other reason that it's kind of good that tendons and ligaments don't have a lot of vascular blood flow to them? Sure makes them repair slowly. That's not good. Miss Hendrickson, why is it good that they don't have a lot, in a way they don't have a lot of blood flow?
Well, because it lets it have more connective structures that make it stronger.
It's denser. It's so dense you can't get blood in there, but it's also so dense it's strong.
Mhm.
Yes. Yeah, it's exactly right. It's the trade-off. It's the trade-off. You want more blood, you're going to be softer. This is why you guys eat steak and you don't eat tendons. Right? Because you're chewing tendons all day long. We've all done that by accident. We're like, oh, what's that thing? Anyway. Yeah. Okay. Cool. TMJ syndrome. People will come into, and we're going to get to this really soon, because we're going to be doing the skull and face and stuff starting tomorrow, starting tonight. So people will come into you and say, I have TMJ. They mean they have TMJ syndrome or disorder. They're the same thing. Everybody has TMJ. Hopefully you all have a temporal mandibular joint. Otherwise you'd not be able to answer questions when I call on you. That is the joint between my mandible and my temporal bone. It's my jaw joint. You can feel yours right here if you move your jaw around. That's right. That is your temporal mandibular joint. But usually when people say I've got TMJ, they mean I have TMJ syndrome or disorder, and they've got an inflammation of some type in there. And it's a fascinating thing to work on. Surgery is not very effective with it. And so a lot of people come to massage therapists for TMJ syndrome issues. And we find that with TMJ, I will go over this again, just really quick preview of coming attractions. We find that with TMJ, what's really fascinating about it is it seems to also stem from general shoulder and neck tension. So it's not just problems in the jaw, although we need to work on those, but head and neck tension in general seems to create this locking down. There also might be a real emotional component to it. Oh, you had it flushed out. That's cool. And anyway, but it's a neat thing to work on a massage because you can actually make it better and without surgery. And so I really love temporal mandibular joint syndrome. And sometimes somebody comes in, you work an hour or two just on their kind of upper body. Miss Ablos, please.
I've come to learn that a lot of people hold a ton of stress in several places, but one of the main ones are in their face. You can actually feel knots of stress all along their jawline, and it's tied to emotions. A lot of it is emotional, reasoning behind why it is the way that it is. So anyway, I just think that that TMJ syndrome is a reflection of our internal reflection of what's emotionally going on at times in our lives.
Yeah.
Do you think that's probably accurate?
I 100% think it's accurate. And if somebody is doubting that, which I would have 25 years ago, I would have said, oh, come on. Why are you making everything emotional? I 100% believe it now. There's lots of good reason to believe that nowadays. Let me give you some examples. They've done studies that if you, I'm going to use my own pen. If these are scientific studies. These aren't, somebody just doing this. If you hold a pen in your mouth like this for 2 minutes, and they check your serotonin levels and your, what's the other one? I can't think of the other one. Anyway, in your body, they raise. These are your happiness hormones. The fact is that just the act of being forced to smile, and I'm not smiling, right? But I have to hold this pen. I have to kind of go, this crummy smile, actually makes you happier. It's proven. It's proven. And so a lot of people say, thank you, dopamine. Thank you, Miss Severino. A lot of people, conclude that rightly so, by the way, that you kind of follow the leads of your face, right? If I walk around and smile, it's harder to be depressed if you smile. And if you fake it, by the way, and start lowering your mouth, you start to get depressed too, right? So we do, the way we carry ourselves and the way our face, expresses itself, definitely tells us what mood to be in, and our mood definitely tells our face what to be in. There's a real connection here, and this is why facial massage is really important. I think with TMJ, Ms. Avalos is dead on accurate. I think that we see lots of people really display their stress up here, and it becomes a negative feedback loop where their stress is showing on their face, but their face is telling them they are stressed. And lastly, I think that, and this is not true in all cases, be very careful that when somebody comes in with TMJ, you don't say, aha, this is your emotional thing. I'm not suggesting that at all. But I think in a lot of cases, we are all under stress in our society to keep our mouths shut. And I think that because you can't always speak your mind, and you shouldn't, by the way, always speak your mind, but there are a lot of situations where you are feeling and thinking something, and you can't express it. And when that's happening, what part of you is saying speak up, the other part of you is saying be silent. And when you send mixed signals to an area of your body, I think it causes dis-ease, unease, because you are not in alignment, you are not matching up. You're telling you've got the gas on and the brake on at the same time. And so I think we see a lot of TMJ with that, where somebody has a lot of repressed frustration or whatever, wanting to speak up when they can't, things like that. Miss Savarino, please.
Yeah, like definitely going like off what you're saying. Like it's important to have a space that's like you can healthily release what you like wanted to say, or journal, go to a rage room, smash some shit out. But I wanted to say, as far as like the muscles and like the joints in the skull, are we gonna learn about like sinus pressure releases? Cause like my friend this weekend had like a lot of like sinus pressures. Are we gonna learn how to like drain those? And like his face just felt weird. Like the bones of like under the eyes were like really like deviated and like up. Yeah. So like, are we gonna like learn how to like do that or no?
I mean, the short answer is no. But the slightly long, but two things on that. The slightly longer answer is we are going to learn about all the muscles that can cause pressure in your skull. Mm-hmm. And that would help. But it almost sounds like you're almost getting to the level of like lymphatic kind of massage in the face.
Okay, so that's what you need to like go study in order to like learn how to do that.
Yeah, and by the way, this doesn't help you directly because there's a cost to it, but we're getting ready to bring in a lymphatic specialist in to teach a course literally like 2 days after you guys graduate. And it's like $400 or something, but it's like a 3-day course or something. She's quite good, and she does a whole body. And if you wanted to pay for it, you could continue your education. I think we're going to have it at the Washington campus, probably in your massage room 3 days after you graduate. And that would be an option for some extra stuff. You know what I mean?
Yeah.
But I'm sorry because there's an expense to it. It's not cheap.
Yeah, no worries. I was just wondering if like we were going to like cover like the basics of just like what this like sinus pressures and just like stuff like that. But anyways, that's it. Thank you.
Thank you. Okay. All right, moving right along. Let's see. Okay. I'm skipping over some of these because I think some are more important than others. Let's talk about fibromyalgia. The reason this description says fibromyalgia, what does it say, is a disorder characterized by widespread musculoskeletal pain. If you think about it, it's kind of a weird thing to say when you describe a syndrome. It'd be like the mechanic saying, yeah, your car is making a noise, and we call this noisy car syndrome. Okay, that's great. What caused it? And the mechanic's like, well, we don't know. That's what medical science is telling you here. They're saying we call this condition when people have all this neuromuscular pain throughout their body and they're tired and they have a hard time sleeping, we call it fibromyalgia, but we're not telling you what it is because we don't know. Now, it's not surprising the human body is very complex, but just remember, if they don't know what the cause is, it doesn't even mean that everybody showing these symptoms has the same reason. We forget this often with fibromyalgia and other things. If two people are sad, they're often sad for different reasons, not the same reason. And if two people have fibromyalgia, we're not even sure they are the same cause. Mr. Craven, yes, sir.
This kind of like ties into that because I remember we went over pain like really briefly and how it's like literally different for everybody because it like brings in like past trauma and things that have happened to you and like all these different variables. And like to add on to that, like you could tell somebody that you're in pain, but if you can't see it, you can't narrow it down to like where it's coming from or anything. So it's, I guess that's kind of like what that is almost.
Yeah.
Because it's just like unlocalized pain. You can't really tell where it's coming from.
Yeah.
Just kind of like word of mouth almost.
Yeah. Yeah. Well said, sir. You're absolutely right. And the good part about them naming it is that people don't feel like they're crazy, right? Because they're like, but I have all this pain. And so it is something recognized by the medical community. But I just want to point out the fact they don't know what causes it. So it's not quite simple. Like, when you guys have COVID, we know you have the COVID virus causing it. We know exactly what caused it. We know exactly what's going to happen. We know when it's going to go away, basically. A lot different when you have fibromyalgia. Ms. Hendrickson.
Oh yeah, I just wanted to comment on there's this guy in the book, there's a little blurb about him in the end of one of the chapters, but I watched these, there's like TED Talks and some videos on YouTube by the same guy, and he's a pain scientist. His name is Lorimer Mosley. He's Australian, and he's pretty funny too, but he kind of explains a lot about how pain works, and it's really interesting for anyone who wants to check it out.
And what's interesting, I mean, there's lots of interesting things about all this, but what the problem with fibromyalgia is it also causes people to be kind of depressed, right? They're in pain. And when you're depressed, guess what? You feel more pain. And when you're depressed, you feel more fatigue. And by the way, we know that lack of sleep leads to muscle pain. That's pure and simple. That's a proven fact. So now you've got this person, this cycle where they're like, I kind of hurt all over and I don't quite know what's going on and I can't sleep well and I'm depressed, which makes me hurt all over and I can't, right? And so massage tends to be terribly effective for fibromyalgia. And you will get two radically different types of you'll get 5 million different types, but two radically different main types of fibromyalgia sufferers, the way they present and what they want from the massage. Some really are like you have to touch really lightly and they're getting used to touch and they're like hypersensitive.
Yeah, I've already had like 2 fibromyalgia patients already in clinic.
Yes, and that's very common, but I want to tell you, like everybody's like, oh, go light on fibromyalgia. No. With those people do, like let them set the pressure. By the way, 100% okay to work on fibromyalgia all day long. All day long. No contraindication. Go light on the people that need it light, but there are some people that have fibromyalgia that actually like deep work done on them. Please do it on them. It's completely okay. It's kind of this misnomer, and I've noticed very different stuff. Maybe they have different types of fibromyalgia because we don't know what it is, but they want very different things. Give them what they want.
Yeah, that's cool.
Ms. Carrillo.
I have a question about how to recognize it. Would one of the things be it feels like it tickles them at first, but if you go deeper, then it hurts?
Yeah, so that's, I mean, yes, that's possible. That's, their nerves are hypersensitive, and so they'll feel tickly, and sometimes going deeper helps. Just depends. And a lot of times you have to use very flat pressure, right? Like I keep my fingers flat as opposed to going in, because that tends to make them much more pokey and aggressive and stuff. Yeah.
Yeah, that's what I noticed. So I also massaged my sister-in-law, and I started off with compressions first, and there's no history of fibromyalgia or anything. Started with the compressions, and then when I started, she's like, oh, but avoid my scapula because, where my rhomboids are at, because people tend to try to lift that and it hurts. And I'm like, okay, I'll go easy on it for you. And it was like super hypersensitive. And then there were moves when I did this, and it was sensitive to her, and it was like a light. I was doing like very light, close to medium, and it hurt her, but she liked the flat, broad stroke. So when you said that, it like clicked. Yeah. So I was like, oh, but I already talked to her about it. I was like, you might want to look into it. I don't have any confirmation. I can't diagnose you, but it's a possibility because this is it's so weird. I know we're not supposed to say like this isn't normal, but I was like, I've massaged a lot of people, and she said, like, the doctor said it was because of her weight, and I'm like, I've massaged people bigger than you, and they're able to handle a lot, and this is unique.
This is unique. Yeah, it's unusual. I mean, it's hard, by the way, it's really hard working on people because everybody's different. Period. Right? But then we do get some people where we're like, oh, this doesn't seem normal different, I guess is what you're saying.
Yeah. Exactly.
And by the way, I think there are huge, in general, emotional components to this. Many people have abuse in their in their background, physical or emotional. and that tends to make their bodies lock down and can make some people hypersensitive to touch, and they just don't want you to get in there, so to speak. And it does not help them, by the way, to tell them, oh my gosh, your shoulders are tight, you must have trauma. Don't do that. All it does is make them feel even more exposed. But in your mind, you might say, I'm dealing with a person with probable trauma here, and so treat them that way, because often as you build trust with them and slowly go in deeper, you start to find out this syndrome they had just kind of disappears. You know, because it's really more about, I'm wounded, very legitimately so. And so that's the bigger component of massage that you guys are really entering into now. Mr. Richards.
Yes, if it depends on mood and your lifestyle and sleep, and how can you tell it's myofibrosis?
You can't. You can't.
That's what I mean. It's a really difficult one because if you're not sleeping and you're not taking care of yourself, it's going to ache, your body's going to hurt.
I don't know if this helps you, but when people tell me they have fibromyalgia, in my head, I don't mean this unsympathetically. I think, oh my gosh, you're in pain. I totally get that. I have empathy when they tell me, but I literally think I don't care. I could care less what you label that as, right? I can work on you. I think massage will actually help alleviate some of your emotional stress. It'll help you with, if you have trauma, it'll help you feel safer. We'll get rid of some of your aches and pains. You're going to sleep better, which is going to start this cycle. And so I just think of it as like, oh, I've got a possibly depressed person, probably actually, in pain here. Let's work on them. That's all I think. And I don't care what you diagnose it as. Yeah.
So the diagnosis could be wrong in most cases, right? Because they just give that. How do they test whether it's definitely that for a fact?
Well, they test it by having it meet their own standards. Right? If I define that everybody with 3 rolls of tape has 3-roll tape syndrome, then I just go, well, you've got 3 rolls of tape, you have 3-roll tape syndrome. But one person says I have the 3 rolls because I'm a painter and I have to tape off this room. Another person says I have a school teacher and I like to tape off muscles. It doesn't, they literally name it by, oh, if you're sore in 12 or more spots, then you have fibromyalgia.
And it can go. It can come and go, can it?
Sure.
Or is it just, we've got it, it's there?
Oh, no. People do get rid of it for life, yeah.
Okay.
Yeah, absolutely. It is not a sentence. It is not a life sentence. Yeah. And I like to, in situations like this with temporal mandibular joint syndrome and fibromyalgia, I like to completely honor that the person is miserable, but I actually try to kind of stay away from the diagnosis because the diagnosis sometimes keeps them stuck. Because they tend to be like, I've got fibromyalgia. Oh, okay. What can we do to improve your sleep? Well, I got fibromyalgia. What can we do to improve your lifestyle? What can we do to improve your flexibility? What can we do to make you feel safer in massage? What can we do to loosen up these tight muscles so that you feel better? And they just saying that you have fibromyalgia over and over again, I get it, you're miserable. I'm not denying that, but it doesn't help me. It doesn't help you either. Right? It becomes a self-fulfilling prophecy.
And I think it limits, because they think I can't do this and I can't do that and I can't do this because I've got this.
Yes. And by the way, I'm sure there's people in this class with fibromyalgia. I'm not saying it's not legitimate. I'm not saying that at all. I'm saying that there are things we can do to work on it. Yeah. And I am there as it's like the gratitude thing where I do, you know, like poor Mr. Singletary. He shared something really, really sad with us today, and we love him. But part of my job as a therapist is to love him, feel sad with him, and then say, what do we do to move this forward in love, right? And telling somebody they have fibromyalgia over and over again and they're just stuck doesn't help them. So I try to get them unstuck, yeah. Without, by the way, disregarding where they're at, right? You gotta really honor, this person's miserable. But I love them, so how do we move them forward? Yes, Mr. Singletary, please.
Yeah, I agree with Miss Hendrickson because I think I know who she's talking about. Because when we were in clinic, she's shaking her head. Older woman, she walked in the door. I've got fibromyalgia. I know I booked 2 hours with you. I'm not going to make it. That's how we started the conversation. I was like, okay, all right, we're going to fight this. So Miss Hendrick, if you ever get her again, make her drink a lot of water.
Emily?
Yes.
Yeah. So sweet.
She is. She's adorable. Get her to drink a lot of water. She not only did she make the 2 hours, she wanted more. Okay, and I ended up doing deep tissue work on her. Believe it or not.
Wow.
Okay.
So Mr. Singletary.
It's all in my head.
Yeah. By the way, I don't ever tell clients it's all in their head, even if I think it, because when people hear all in their head, they think it's not real. I think everything's all in our head. Like, I mean, everything's all in my head, so I'm not discounting it that way. But yeah, Mr. Singletary, this is your superpower that I was talking about. You took her and you were able to make her feel safe with this diagnosis and then lead her gently away from the diagnosis.
Mm-hmm.
While honoring her, by the way. If you rip her away from the diagnosis, that doesn't honor her. And that what she's telling you is, I don't feel good. And you got to be like, I get you don't feel good. Let's start making you feel better. And you did a beautiful job, sir. I mean, that's massage to me. That's it.
I didn't dismiss what her problems were.
And you didn't feed into it.
Right.
You didn't dismiss or feed into it.
Else. Yeah, when you walk into a massage and go, I can't.
Yeah.
Okay. All right, I'm going to fight through this. And I'm going to turn can't into can.
Yeah, and that's exactly it. And by the way, guys, to keep your sanity too, you move people along as far as they're ready to move that day. It might be very, very little, right? I do that with you guys as students. I mean, I'm sorry, but some of you are better students than others, right? You're putting more effort out there or less. And I'm not putting anybody down. That's just a fact. We all know that, right? Well, so some of you I push along a lot farther. Other ones I can't push that far. No matter how hard I push, you're only going to go as far as the effort you're putting in and such. So you try to move your clients along as far as they will let you move them comfortably, and then you stop. And then you wash your hands of that. Physically and mentally, you wash your hands and move away. That's all I could do with so-and-so today. I did my best. That's it. Because they're really setting the progress. Otherwise, you'll go nuts. You'll go nuts. Because you can't get them to heal as fast as you want. Myofascial pain syndrome kind of ties into this other thing. It's another thing they've come up with. Just don't worry about it. Just massage them. Love them, massage them. That's my answer to all this. Love them, massage them. Love them, massage them. Don't rub anything swollen. That's it. It's the whole lecture today. Okay. Osgood-Schlatter disease. Remember this? It's not important for a skimmer. I'm sorry. It's an overuse syndrome, but it's nothing to worry about in massage. Plantar fasciitis is. You will have people come in with plantar fasciitis. It's an inflammation of the plantar fascia. Where would I find the plantar fascia? Ms. Carrillo?
At the bottom of the foot.
Thank you.
Thank
you. Plantar fascia is in the plantar region of your foot. It's the bottom of your foot, and it's very spongy, spider-like stuff that gives flex to your foot. And when people overuse their feet, the muscles start to get tired, the fascia has to kick in, and after the fascia gets really tired, it gets inflamed. And it's a really tricky condition. Some things to consider with plantar fasciitis. By the way, for a lot of people, it gets worse because what happens is when they wake up in the morning, their feet are really stiff because the fascia's cold. And so their feet really hurt. And as the day goes on, sometimes they hurt less because they get warmed up. And so people that are like runners that develop plantar fasciitis will actually tell you, well, it feels better while I'm running. And it does. They've got a lot of blood flowing in there and it feels better, but later it feels worse. And so they've got to really realize that it's still an overuse injury. They are using their feet too much and they have to cut way back. By the time they got plantar fasciitis and their feet hurt that bad, they've got to stop running and start walking, which is really hard for a runner to do. But not only runners get plantar fasciitis, all sorts of people do. It can be related to your weight too, because if you're really heavy, your feet are carrying more weight. They just are. But it can be, associated with bad shoes and standing too long and all sorts of stuff. Anyway, stretching the plantar fascia out and rubbing the feet really, really helps. But so does lengthening all the plantar flexors of the foot, because they all essentially connect into the heel and go into the plantar fascia. So in a world of fasciologists, the gastrocnemius, soleus, and plantaris all come into one tendon, the calcaneal tendon, which sews into the heel and becomes the plantar fascia. Your foot actually has a bow and arrow effect. And it's as though the ankle's pulled back like a bow pulling back. And that's actually how you control shock absorption. So when you have somebody with plantar fasciitis, definitely hit the plantar region, but really, really hit the posterior leg. All of it. I mean, I do the whole darn leg, but definitely posterior leg and plantar fascia. And believe it or not, hitting the hamstrings isn't a bad idea either, because they tie into that whole back fascial line. And that's really a big issue there. And then, again, you can only push the client as far as they want to go. They've got to back off whatever activity was doing, heavily back off whatever activity they were doing that got them there. And that's trickier, right? And I've told many clients, they go, well, I'm getting a massage, every week, and this isn't getting better really fast. I'm like, well, I get to see you for 1 hour a week, and you're doing this stuff to your body like, 12 hours a day. So it's really hard for us to reverse all that if you don't start making some lifestyle changes. I say it nicely, right? But it'd be like you guys saying, well, you're teaching us anatomy every day, but I'm not learning that. I'd be like, well, are you studying, though, in the in-between time? Like, I only have you for so much time out of the day, that kind of thing. A plantar fasciitis, you will get clients. Massage does help it. It helps it a lot because it gets blood flow in there. Definitely take those clients. They're wonderful. Do lots of work off the heel to loosen all that stuff up. And that's it. Shin splints. Shin splints is a term that is used for all sorts of stuff. Kind of to Mr. Richards' point about fibromyalgia, shin splints can actually be several things. Shin splints can truly mean microfractures in your tibia or fibula. And that's what they used to mean all the time. Now people use the term, including doctors use the term, to mean any type of pain down in there. Any type of pain in the tibia, and it's usually the fascia around the tibia. Anybody remember what fascia around a bone is called? The fascia around a bone is called? I've got hands up, but Mr. Craven, I don't think. Mr. Craven, do you know what fascia around the bone is called?
No.
All right, hold that thought then, sir. Miss Clayton, do you know what fascia around the bone is called?
Periosteum.
Thank you. Periosteum. Osteo, remember bone, guys? Periosteum. And that fascia, if you think about it around your tibia, that tibia has all these muscles hooked to it, and they're pulling on the fascia, and it gives you that deep ache inside your shin where you're like, it almost feels like it hurts inside my bone, like I've got shin splints, like I've got little fractures in there. Well, you might, but most likely you just have kind of irritated fascia because all these muscles hanging on it, and that shin splint responds very well to massage. Very well to massage. And remember all the stuff you know when you're massaging it. Like if the tibialis anterior, which is in front and lateral, if that muscle can create a dorsiflexion, if I put it in a plantar flexion and rub it, I'm stretching it while rubbing it. I'm doubling the power of my massage. So I tend to push down on the foot when I'm rubbing the tibialis anterior, and I lift it up when I'm rubbing the peroneals or the fibularis to get extra stretch in there. It's very effective. Do not forget about actions of muscles. You use it to turbocharge your massage. You want to be better than other therapists. Mr. Craven, what do you want to say, sir?
So we have sprains and strains.
Yes.
So could a splint possibly just be like that version, but like related to fascia, not necessarily like anything else?
In this case, you're 100% correct. That's exactly what it is. This is really to me fasciitis of the shin.
But so it only has to deal with a shin. You couldn't have like a splint in some other fascial area.
You couldn't, because that's how the term is used. It's used just with your shin splints. But I love what you're saying. We should start calling that like humeral splint, which is like the fascia around there. Yeah, any periosteum annoys the word, but they don't use it that way. But I really like what you're doing. We'll start doing it that way, you and me, Mr. Craven.
Perfect.
We're gonna change the medical world. Yeah, I love it. Okay. We already talked about strains. Strains are with muscle tendon usually. Tendinitis, tendinosis, tenosynovitis. All this stuff is inflammation around tendons. Everybody, don't even worry about it. When you hear tendon and itis together, inflammation, right? Let's go on to tension headaches. I love tension headaches. I don't love that people suffer for them, but I love them because they are exactly what they say they are. They are emotional and physical tension causing a headache, and I love them because they can be instantly solved with massage. I've had many clients come to me when they have a tension headache because we can solve the tension headache in that one session. I'm not saying it won't come back again, but my point is massage is phenomenal at tension headaches. If that's why the person is there, I'm often like, hey, can we just work kind of your upper body up to your head and stuff? Because I want the full time spent on like neck, shoulders, chest, serratus anterior, pec minor, scalenes, sternocleidomastoid, temporalis, masseter, all your occipitals and back, all these muscles back there. But I want to spend time on all that stuff because it does it. Works every time. Because your head has all these muscles hanging off it, and your shoulders are actually suspended from your head. And if we can release all that stuff, we literally stop compressing the skull in a vice. And they're like, oh my God, I feel so much better. And there's not a lot of things in the massage where you're like, during that one session, they're like, yep, it's gone, thanks. Tension headaches. Yeah. So if somebody comes in, I often ask them, is this why you're here? And they're like, yeah. I'm like, can I focus the whole session around that? I'm like, we're not getting to your whole body. We'll get to a third of it, but we'll do it really thorough and it'll be really effective. And usually they're like, yeah, because their tension headaches why they're there. Kind of a cool thing. Definitely not a contraindication. Torticollis is also called wry neck sometimes, where the neck muscles on one side are contracted, and that really responds well to massage too. Somebody, for whatever reason, has kind of contracted stuff here. You'll look at them, they look unusual. And as long as you can slowly kind of stretch them out, remember, we don't force anything, but you can put some pressure on it and start to work it out. It's very effective. Whiplash is fine to work on too from a car accident. But how long should we wait after somebody's car accident to work on them? What's the bare minimum we should probably wait after somebody has a car accident? Miss Clayton.
48 hours?
Yeah, that works for me. 48 hours. Yeah. I think before 48 hours, it's highly likely they're going to keep feeling more and more pain, and it's not the time to work on them. Now, by the way, if they come to you in 48 hours and they're swollen, then I'd say it even needs to be more time. But I'm saying Miss Hendrickson, who was unfortunately in a car accident, comes in and says, hey, I got in a car accident 48 hours ago. She's not showing any swelling, things like that. I would do massage her, but not before. And you will get clients, I promise you, unfortunately, they come to you and they're like, oh my God, I need this massage so bad. I was in a car accident. I'm like, oh, when? Oh, on the way over here. No. And I almost never say no. I mean, I am one of those guys that's like, sure, we can rub your feet. But I'm like, no, you just got to cry. Like, who knows what's going on with you? And they're going to blame it on the massage the next day. And they might even be right. Like, I don't know what's going on. So 48 hours, And of course, in those situations, we say, look, I'm not charging you because you're not going to have to eat this very often. I'm not charging you. I'll reschedule you. And I always make it about them. It's because I care about you. It's very hard for people to get mad when you say, and it's true, I'm doing this for you. Like, I want to rub you. I want the money. But I care about your health more than that money. That's very effective. Ms. Creel, please.
When I listened to this audiobook called Never Split the Difference, what helps is that you make your problem their problem. So I would probably say, like, I think I would do more harm than good. It's just best for your health and things like that. That's the way to get them agreeable to you, to make your problem their problem.
Yeah, it's very true. Yeah, and don't let them make their problem your problem. Right? They're the one who got in a car accident. That's not your fault, and you're trying to protect their health. And by the way, guys, if you work on them thinking that you're making them happy and they get worse, you're liable, not them. So, you have to make those ultimate decisions. And it's rare. Again, it's rare that I turn a client away. But there are times where I'm like, well, you're just in a car accident. Let's make sure. But if you have brain bleeding or something, let's give it 48 hours. Let's just make sure. Bruises. What's important to remember about bruises? What kind of contraindication are they? And what's important to remember about them? Somebody talk to me about bruises. Miss Clayton, talk to me about bruises.
They're a local contraindication, but they may not even, if they don't have any pain, you can still massage it, but you always want to point it out so they don't think you caused it.
That was it. Could not have said it better myself. Thank you, Miss Clayton. They're a local contraindication. If they don't hurt, you can massage them, because lots of people have those, kind of bruises that stick around for a while. Go ahead and massage them, as long as it doesn't hurt. But that's the perfect time to bring up the conversation of, oh, does this bruise hurt? And like 9 out of 10 times they're like, I didn't know I had a bruise there. Oh yeah, but as long as it doesn't hurt, don't worry. But I did that because I do care that it hurts. But I also did it because I want Betty Lou to remember that she's got a bruise on the back of her leg, because Betty Lou goes home and her husband or wife says, hey, you've got a bruise, it must be from your massage. And she's like, oh no, my massage therapist actually pointed it out to me. I don't know where I got it from. And we have that happen at the Princess all the time. Like, people would come back and their spouse would be like, you bruised them. I just saw a bruise there. And the therapist would be like, it was there already. That's what we pointed out. Point out bruises all the time. It just saves you a little bit of headache. And you need to find out if it hurts or not. So, that's that. Boom. We don't need any of that. Eczema, by the way, which is kind of presents as really, really dry skin, is just a local contraindication. We just don't run it. It's just, and you'll see it in lots of people, and people with it tend to be very embarrassed about it. Tell them it's normal. You see it all the time. Miss Ablos, please talk to me.
I notice with people with eczema, if you do more compressive type work, they respond better to it.
I like
and
that.
Any type of small detailed movements can just inflame that entire area.
Yeah.
Is that how we're supposed to address it, kind of, if we do want to do work on them and they have eczema in that area?
I think it's brilliant. Actually, I really do. I think it's brilliant. So, if they're okay with you working on it and it's not bleeding and things like that, yes, doing compressive movements makes a lot more sense than digging in there, right, and scratching it, so to speak. And I think that's okay within reason. Yes, I really do. Absolutely. And it also displays the kind of common sense you need as a massage therapist, which is just kind of like, oh, I kind of know what this is. The skin's a little thin and irritated here, so it's probably not the time to dig here. So I love that kind of rationale. And Miss Young, you raised your hand but then took it away.
I was just saying that, like, some are different, and I guess it's not too big of a deal unless it, like, kind of irritates them.
Yeah.
And for me, biotin is excellent. So I guess it also depends on, like, where it comes from, because mine is, like, allergy-based.
Yeah.
So I can just take allergy medicine, and mine is pretty, like, easy to get rid of, and then, like, steroid-free.
Yeah. Yeah. And a lot of people's it's stress related, and so not allergy based, it's stress related, and so I just like to always kind of bring their stress level down. With a lot of this stuff, it's people's bodies. It's more emotionally reacting to this. I'm not even kind of worried about the contraindications. I'm more worried about the fact this person feels embarrassed and things like that, and I want to make them feel comfortable. Miss Dimitrik.
I had a client that, as I draped the leg, I came across just some different skin, and I wasn't sure, do I ask him about it at that time? I just kind of avoided it.
Yeah.
Because I'm like, I don't really know what this is, so no touchy-touchy.
Yeah. Well, I think no touchy-touchy is always a good idea. You're always safe with that, right? The hardest lesson I had in massage, and I still have to this day, I think maybe others have this problem, but definitely as a massage therapist and a manager and things like that, and a parent, is in general addressing things is always the best way to go, but it's also always the most uncomfortable thing to do. Right? Nobody wants to say, hey, your leg looks funky, is everything okay? And of course we wouldn't say that. We'd say, this area looks a little irritated, or this is it okay to rub your leg? I notice it looks different than this one, or whatever. I have never once in my life had a client get upset with me for doing that, but for some reason, we've all been taught, right, that when you see something unusual, we ignore it. That's the socially kind thing to do. That's what we've been taught, right? We don't point stuff out. That's what we love about kids. Kids are always like, why do you look funny, mister? And they point stuff out to us, right? But as adults, we're taught to actually ignore problems. And as a massage therapist, I find that whatever is going on, if you address it, it's better then. People will explain it to you. They already know more about their condition. And that's true with their behavior, too. Addressing it right away tends tends to make a big difference. But that is a hard lesson. It's hard when you're a parent or a manager or a teacher or anything or a friend to bring up this stuff of like, hey, I really like you, but let's talk about this and not talk about it in a generalized kind of situation. So, Mr. Metrick, yes, you were safe by avoiding. In the future, I would feel completely fine, and I actually think you'll be even more successful if you just bring it up. Most people are like, oh yeah, that's blah, blah, blah. Yeah. And it's okay to be ignorant, everybody. You guys are not doctors. I know that some people think you are, but I'm sorry, 9 months of education does not equal 12 years of education with 4 years of internship in a hospital. You have 9 months of education. You are not supposed to know about every disease or anything. You are qualified to rub on people and keep them safe. And you're qualified to know when to not rub on them. But there's lots of situations where people come in and they're like, blah, 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 blah. And I'm like, what is that? Oh, well, done it. And they talk to you about it. Let them talk to you about it. They're going to educate you. They know what's best for them. Yeah. Mr. Richards.
Talking about safety, when is the massage board meeting again? Because I'm interested to see what happens with that guy that's,
It is this Monday, I believe. Let me check right now.
Are we going to be doing it with it during class, or are we?
It is during class. And so based on what I learned from the last meeting, you guys were all really nice and shared all sorts of different opinions about this and stuff like that. I think what I'm going to do is I'll give you a choice of either being on that meeting or doing, I don't know, maybe review with one of the other instructors during that time. I don't want to force people to watch the meeting because I really got that it can be triggering, and it made perfect sense to me, and I apologize for not thinking that way, but I've learned. But I also recognize for some of you want to be on the call, and I think it's great. I actually think it's a really great thing to see. It makes you think about behavior in light of like, how would I justify what I'm doing in front of a board, right? So anyway, that's this Monday, sir. And yes, my short answer is you will have an opportunity to watch that. That's my intention.
I think it just gives us insight to what people feel is inappropriate and not inappropriate.
Yeah.
I mean, because justifying things like that last one, he was like, well, I've been doing it for 5 years and I kind of got distracted, but I ended up in this area. Well, how did you get in that area when you've got all these, things that you have to overcome to get to that area? So it was very...
Well, if you're talking about that guy, we already...
No, I'm not talking... I'm just saying, like, very interesting to learn about, how you can justify certain things.
It does. Here's what I find it helpful with, and by the way, I could make these type of mistakes. I didn't, thank God, but I could. Like, it helped me recognize, too, like we had a guy in there who was like, I had consensual relations with a client. The client says 100% consensual. He says 100% consensual, right? So that's not an issue, and yet he still got himself in big trouble. And I think it's very helpful to realize that what you kind of think is innocent, if you had to explain it to a group of people, it sounds very different. And I often ask myself, by the way, when I'm teaching or doing something, how would I feel if I had to get in front of a board and explain this? Like if I had to explain, like, yes, I reprimanded Mr. Richards because of blah, blah, blah. How would that sound and what was I doing? Or yes, I made that joke. How would that sound? And it's very helpful kind of governor for me to be like, oh, that's not wrong what I'm doing, but it's sure going to sound wrong if I had to say it in front of a group or if I had to put it in an email. Stuff in black and white sounds terrible, right? I told you guys the story of the princess when somebody was massaging me. So we used to do massages really quickly. We used to do massages I'm going to stop sharing this because we're right towards. I used to do practicals. People would come massage me for their interview after hours because we couldn't massage them during hours because all the rooms are full. So that was all in the up and up. But security once walked in and I was getting a massage from an applicant. All fine, nothing weird going on. But the next morning my boss called me in and said, hey, we just have to clarify the security report. And I read the security report and it said, found manager Tapscott in a room naked with a non-employee. Now that's the truth. That's exactly what they found, right? I was covered. The non-employee was giving me a massage. There was nothing questionable about it. But in black and white, things look bad. Really bad. So that was very easy for me because they knew I was supposed to be doing interviews and we didn't even stop doing it. But my point is, it's when I realized, like, oh my gosh, things in black and white when you can't, they don't know you. We don't know you in front of the board. You can't be like, I'm Mr. Richards. Everybody loves me, right? I'm a good guy. We're like, I don't know. Found naked in a room. with a non-employee. Sorry. Everybody, I released your homework for tonight. I know some of you are like, what homework? There is a tiny assignment due for tomorrow. There's a giant assignment due for tomorrow, but hopefully most of you have done that. The tiny assignment is Trail Guide Chapter 5, Introduction. It's 5 points, and it's due tomorrow. So you actually have 2 assignments due tomorrow. Obviously, if you have to choose, which I hope you don't have to choose, but if you do, do the one that's worth 2 million points and not the one that's worth 5 points, because that is going to make a big difference in your life. Yeah. Do we have any? We've got like 6 minutes left. Do we have any questions before I give you 6 minutes to make sure you can see your homework? Yes, Mr. Richards, please.
Any news on the Four Seasons?
No. But by the way, don't worry about this hesitation. I still feel pretty good about it. I just had my people just this morning resend the paperwork to them to kind of nudge them along. And like I said, I had a very good meeting with them. I feel very positive about it. The problem is it really does come down to the GM of the hotel, but if I was and I am a gambling man. I don't mean that I go gamble, but I think it's going to come through, sir. I just hate making promises that, you know what I mean? I don't know. But I know we need a backup plan, but I think right now we should even just stick with 4 seasons, 4 seasons, 4 seasons. I feel fairly good about it. I really do.
I've stopped gambling because Talking Stick wouldn't take me the next time, so they're not having my money either. So.
Yeah. The other resorts have been really difficult. Really difficult. They're just, resorts have more people applying for them still. They're not quite desperate enough. Many of them said, we'd love to have your student lists and reach out to your students. The other thing is they don't want to take you guys during externship because they don't want to tie up a massage room because they're very profit driven. So it's not about you. It's that if you they don't look at massage therapists, by the way. They look at massage rooms. So, and Miss Clayton, even though I'm sure loves her employees, I don't mean like that, but she probably looks at it that way too. She has a certain amount of rooms and you want to maximize your rooms. And we're like, hey, let's send you a couple students and you've got 2 rooms offline, so that you won't make about 10 grand that 8 days. And that's a lot. They're like, we won't make 10 grand? Like those rooms generate a lot of business at a big resort. I think that's what they're worried about.
I'm just trying to think of my options for the next, just in case it, fails. I'm just thinking about my options for a 2 and a 3 kind of thing.
Yeah, no, I know. Do. And if you want to send me any other place to kind of hit up, I'm happy to.
Okay, thank you, sir.
Yeah, when I said, you're right, we should have backup options, but I'm still feeling pretty good about 4 seasons. Miss Rader.
I was just going to mention that I just read that the